Good afternoon and welcome to today's IAC webinar, Stress Selection, Exercise is Key, but Sometimes You Need a Pharmacologic Boost. My name is Kelly Baer and I'm the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will be monitoring questions throughout the presentation and will try to answer as many of them as possible during the Q&A period. Also on the left side of your screen is the Resources tab. Click this tab for a link to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the ARRT Category A CE credit, you must be registered, logged into this webinar, then complete the survey. The survey will appear on your screen automatically at the conclusion of the live webinar and also be available from the IAC Webinars portal for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. And now I would like to introduce our guest presenter, Dr. Jamieson Bourque. Dr. Bourque is the Medical Director of Nuclear Cardiology and the Stress Lab at the University of Virginia Health System in Charlottesville, Virginia. Currently, he is Associate Professor of Medicine and Radiology at University of Virginia. Dr. Bourque specializes in advanced cardiovascular imaging, management of coronary artery disease and ischemia, and coronary microvascular disease. He has a clinical and research interest in patient-centered imaging, and we are happy to have him with us today. And with that, I will now turn this webinar over to Dr. Jamieson Bourque. Doctor?
Thanks, Kelly. I appreciate everyone joining today, and hopefully we can have some good information here. Just quickly, disclosures, I do receive research grant support from Astellas Pharma, but the research is unrelated to this topic. For our learning objectives, my hope is at the end of this hour that you'll be able to illustrate the importance of exercise stress through a variety of clinical scenarios we'll go through. I hope you'll be able to summarize the effects of inadequate stress on the identification of the presence and extent of obstructive coronary disease. And I hope that you'll be able to compare and contrast protocol safety and patient tolerability of a combined exercise pharmacologic stress protocol compared with exercise stress alone. So the first thing to note is if we look back at the exercise testing guidelines from 2002, which there's one of the diagrams here, fairly complicated, and you don't have to go through this whole thing. But the recommendation by these guidelines was that exercise is the recommended stressor. And if you actually look down, and I'll zoom in here, on the sort of relevant part, you can see that they ask, can the patient exercise? If the answer is no, then one is supposed to proceed with a pharmacologic imaging study. But if they are able to exercise, then exercise is the preferred modality, either with imaging or this guideline actually suggests that resting ECG, stress electrocardiography itself can be used. So the point is that the guidelines are suggesting that we should be using exercise stress. And there are a variety of reasons for that. And we're going to go through numerous clinical scenarios here that can kind of detail why it's important to use exercise stress. And then we'll talk about what to do for the many patients that can't necessarily do exercise stress or we're not sure if they'll be able to reach an adequate workload. So we'll go ahead and get started. Excuse me. So case number 1 is a 62-year-old male who is referred for the evaluation of exertional chest pain. He has a past history of diabetes, hypertension, dyslipidemia, and sleep apnea, a sedentary lifestyle, and he's had a slow reduction in the sort of things that physical activities that he has been attempting. And so he's referred for an exercise spec MPI, and he only goes 3 minutes on the Bruce protocol, which, as you all know, is not a very long period. He has 2 millimeters of ST depression noted in both the inferior and lateral leads, and those ST depressions persist into recovery, and he develops angina, which is the same as his referral pain. And this is important to note whether the pain is actually the same as what they were actually referred for, was elicited. On his SPECT MPI, he had multiple perfusion defects, and he was referred for invasive angiography, where he was found to have complex multivessel disease, and he ended up having CABG performed. Unfortunately, he had a rocky postoperative course and passed away. And this is not a surprising picture for a very abnormal stress test. And so my question for you to ponder, and I didn't want to take the time to do a poll here, so I just want you to sort of think about it before we move on. What is the most powerful prognostic marker in this case that I just presented? Is it the 2 millimeters of ST depression? Is it the 3 minutes of exercise workload achieved? Is it the fact that he had typical angina during stress? Or is it the fact that he had multiple perfusion defects that were ischemic? And so that's the question. These are all very, significant and substantial. And it turns out that we're going to sort of label this case as low exercise workload. And the reason why is that indeed exercise capacity is the most powerful prognostic marker in that case, and in general has been shown to be the most powerful prognostic marker, and has been shown to have the most impact during exercise testing. It's a significant marker of increased cardiovascular events and of all-cause mortality. And exercise capacity has been shown in multiple studies to be prognostic, irrespective of the severity of coronary disease that they have, irrespective of their gender or what their age is. And here in this figures, the two figures to your right, by Myers et al. In this seminal study published in New England Journal of Medicine, you can see that if you look at the survival curves here, that there's a clear delineation by the number of METs achieved on exercise stress as for the percentage surviving. And they've separated this out into normal subjects and into those with cardiovascular disease. And you can see that there's differentiation in both of these groups. You can note that there's some differences. Certainly the group that has a high workload achieved who had cardiovascular disease appears to have a more rapid increase in events over time. But this is a very powerful prognostic marker. So an abnormally low exercise capacity is very prognostic. Case number 2, we'll look at a slightly different sort of application. So case 2 is a 52-year-old female who's referred to your lab after recent exercise intolerance. She's an avid runner, but lately has become winded after several miles. And this is a change for her from her prior abilities. Her past history includes hypertension, asthma, and a prominent family history of coronary disease. And so she's, despite maybe not having such a classic presentation or risk factors, she's referred to the lab. So she undergoes exercise spec MPI, and she achieves 10 minutes on the Bruce protocol, which is 11 METs, or a pretty solid exercise capacity. She stops due to fatigue. Her spec MPI is within normal limits. She has no perfusion defects and a normal ejection fraction on that spec. But due to her prominent family history, she was sent for a coronary calcium score, and this was positive. She had a score of 20. And because of that, she was diagnosed with presumed non-obstructive coronary disease, and she was initiated on a statin and an aspirin, and she was followed up for 5 years with no issues, and then she ended up moving, and at that point, follow-up was lost. So this is not a sort of unusual case for what we would call high exercise workload. And there's been a variety of data that's looked at this. So we actually, in our lab, were very interested in the concept of achieving a high exercise workload. And in a study, this study was in JACC, not the Journal of Nuclear Cardiology. We separated into 3 different workload groups. And what you can see is, so we looked at all comers to our lab over an entire year, and we looked at the prevalence of significant ischemia. And that was defined as 10% LV ischemia, or similar to what's being used in the ischemia trial. And what you can see here is that there's a marked decrease in the prevalence of significant ischemia as your workload attained increases. And here and you can see 50% of our exercisers reached 10 METs, so it's a substantial group. And you can see that they had less than 1% chance of having significant LV ischemia on their stress spec. And so this was a sort of powerful indicator that high workload is very relevant, and potentially that we might not have to actually do imaging for all of these patients, although that hasn't been fully elucidated. But one thought would be, okay, well, so you identified a low risk of significant ischemia, but some of these patients may still have events. So we actually did follow up to this study where we looked at the 463 patients who achieved 10 METs who had follow-up available. And you can see the survival curve here on the right, and you can see that there was extremely good survival over a 2.5-year period. The cardiac death rate was less than 0.1% per year, and the rate of non-fatal MI was 0.3% per year. So achieving a high exercise workload identifies a group who is very unlikely to have significant events. And we're going to come back to this issue in just a second. But we'll start with case number 3. So case 3 is a 45-year-old male referred for atypical angina. He has sharp pain that occurs intermittently with exertion. He has multiple cardiac risk factors, including hypertension, dyslipidemia, obesity, and tobacco abuse. He underwent an exercise-spec MPI and went 7 minutes on the Bruce protocol, had 1 millimeter of ST depression in V5 and V6 that persisted into recovery. He had angina, but the test was stopped for another reason, due to fatigue, not due to his angina, and this becomes important. So he had moderate reversible ischemia in the anterolateral wall, 12% LV ischemia, and underwent invasive angiography and had a 90% large diagonal where he had a drug-eluting stent placed, and he's doing well in follow-up. And so we'll label this one as positive ECG changes and imaging. So we saw that exercise workload is a powerful variable that we get off of our exercise stress. And now you can see that EKG changes are very relevant. So here's a study that we put forth. It's interesting when we picked this topic, it wasn't necessarily because I had a lot of research here, but it turned out as I was putting it together that there were a lot of things that we had done that were sort of relevant. So I figured I would include them. So Dr. Willett and I and others looked at all comers to the cath lab at UVA over an entire year. And we looked at a variety of reasons for referral. And in that group, there were approximately 300 patients who underwent stress testing as their reason for referral. And you can see here when we look at the 217 or so who received exercise imaging, that if we look at it, positive or negative ECG changes or positive ECG changes and imaging, you can see that if both were negative, you had a very low prevalence of obstructive coronary disease here. This is the far left bar, where you can see 70% were either non-obstructive or normal. On the contrary, if you look at the far right bar, you can see that if both were positive, ECG and imaging, then you had a very high incidence of obstructive CAD. And if one or the other were positive, you were sort of in the middle. And another marker for this, or another score that has been sort of developed to look at this, is the Duke Treadmill score put forward by Dan Mark in New England Journal in 1991. And you can see here if you take the exercise time in minutes and the millimeters of ST depression and their anginal index, did they have any, did it limit their stress testing, you come up with a score. And the score can put folks into low, intermediate, or high risk. And it basically incorporates ECG changes, exercise capacity, and angina on the treadmill. And for our patient in this prior study, I think he had 7 minutes, so 7 minus 1 millimeter ST depression times 5, so that's 2 minus 4 for non-limiting angina, so his score was -2. All right, so case number 4, 72-year-old female referred for pre-op evaluation prior to major abdominal surgery, and she is asymptomatic, but due to the significance of her surgery, they decided to do a stress test, and she does have a past history of diabetes. She did an exercise SPECT-MPI study, and she went 9 minutes on the Bruce protocol, 10.1 MET. She did have 1 millimeter of ST depression and 2-3 in AVF that started late and resolved by 1 minute of recovery. She stopped for fatigue. She had no anginal symptoms. She had normal hemodynamic response, and her SPECT-MPI study was within normal limits. So there's a challenge with what to do when you have a positive ECG and negative imaging. In this case, because of her good workload, her lack of symptoms at the beginning and during her test, she was considered low risk, and she was referred for surgery without further evaluation, and she tolerated surgery really well. So this is another case, positive ECG and negative imaging. And this is a group that potentially you can identify higher risk patients despite the fact that they didn't have a positive imaging study. This could have just as easily been somebody who was otherwise high risk and had really concerning symptoms. And despite the negative imaging, you might have sent them to cath and found obstructive coronary disease. And that is one of the challenges here is the identification of high-risk ischemia. And so in a study out of UVA, we looked at 412 patients who received SPECT-MPI and coronary angiography. And we were looking for high-risk coronary disease, which we defined as greater than 50% left main or a 70% prox-LAD or 3-vessel disease. And what we found was that the most powerful predictor was the positive stress ECG in this environment. And what you can see by this figure on the right was that what we wanted to do was to see how many patients would have high-risk ischemia who had less than 10 METs, greater than 10 METs, and did the ECG identify the ones that were at risk? And sure enough, you can see here in this pie chart that the white little sliver there represents the group of patients who had a high exercise workload and a negative stress ECG. Turned out it was 1 out of 36 patients. So it's not a huge study, and we were looking at high-risk CAD, so that was a small group. But out of the 36 patients who had 10 METs or more, and a negative ECG, only 1 had high-risk CAD. And this is important because with imaging, we have this concern for balanced ischemia, where here you can see images that look relatively normal, but this is a patient that actually has 3-vessel disease. Now, fortunately, I'm not showing you the rest of the study where they had a gated imaging result that was abnormal and they had angina on the treadmill. And so fortunately, they were referred for cath and the disease was identified. So it's important that if you have a greater than 10 METs and a negative ECG, you have a 97% negative predictive value for high-risk CAD. So case number 5 is so I guess we've pointed out that exercise capacity and ECG changes are very relevant, and they're not as relevant in pharmacologic imaging. It is true that somebody who has ST depression during vasodilator stress does have a higher risk of events, and that can be a very specific finding. However, it's not that common and not that sensitive, and so it's just not as good as having the exercise. So in case number 5 here, we have a 48-year-old male referred for typical angina, past history of hypertension. He walks his dog several times daily, but has angina with hills. He went 8 minutes on the Bruce protocol with no ECG changes. He He had typical angina at 7 minutes, causing him to stop the test. His MPI was negative. He was managed conservatively, but over the next year, he had worsening pain, or I guess a year later, he had worsening pain, and his SPECT MPI showed disease, and he underwent stenting of the mid-LAD. So this is our exercise-induced angina case, and there has been debate about whether angina on the treadmill is of significance. Dan Mark et al. In that their seminal Duke treadmill score work found that it was, and you can see here I've underlined in red, they found that the treadmill angina index to be a predictor of cardiovascular death and of total cardiac events. But there have been other multivariable analyses that have not found angina to be a significant predictor. My thought is that if you've got nothing else suggestive, then often I will treat them conservatively, as we did in this last patient. And you can see that he did well for a year, and then his SPECT study did find a disease, but he had a change in symptoms. And so I think in this case, a conservative approach was reasonable. So case number 6, a 54-year-old female referred for chest pain on exertion. So she underwent exercise SPECT MPI, and at baseline, she was a little hypertensive at 142/94. And at peak, she was fairly markedly hypertensive, 234/112. And because of that high blood pressure, her exercise was stopped. At 3 minutes post-recovery, she was still fairly substantially elevated at 220/108. She ultimately received her imaging, and her SPECT MPI was within normal limits. So fortunately, they controlled blood pressure with her blood pressure aggressively, and she had resolution of her symptoms. Unfortunately, 2 years later, she had an inferior STEMI. It was thought to be unrelated to this particular presentation, but she did have kind of a decompensation later on. So there's sort of two aspects to this case that are relevant. One is that the patient had significant hypertensive urgency, both starting at baseline hypertensive and then having a marked hypertensive response with exercise. That very easily could cause increased myocardial oxygen demand and be the cause of somebody's chest pain on exertion. So that could give you the answer, even if the MPI is negative and they don't end up having obstructive coronary disease. The other is, if you look at this graph on the right, you can see that the systolic blood pressure drop at 3 minutes. So the ratio of the systolic pressure at 3 minutes to the peak blood pressure, that ratio has prognostic significance and can identify the extent of disease. So there's additional information that you can get looking at this sort of curve of the blood pressure. So there are two aspects to blood pressure that are important here. Case number 7, a 74-year-old male referred for exercise intolerance and dyspnea on exertion. He underwent exercise SPECT MPI, 7 minutes on the Bruce protocol. His peak heart rate was 154, which was over 100% of his maximum age predicted heart rate. So a very robust heart rate response. And when his heart rate was looked at 1 minute post-peak, it was down very little at 149. Now, his SPECT MPI was within normal limits. Because of this sort of evidence of what we thought was likely a component of deconditioning, he was recommended for a significant exercise program. And unfortunately, 6 months later, after his exercise program and not related to this, he had sudden cardiac death. So this, again, is identifying a prognostically significant group of patients. So if you look here at the graph on the right, you can see that if we look at the number of beats per minute drop in heart rate from peak at 1 minute post exercise, you can see that the sort of quartiles show you the relative risk of mortality at 6 years. This was a 6-year mortality thing. And you can see that if you had less than a 10 beat per minute recovery, and really almost less than 15, your relative risk was very substantial for mortality over the next 6 years. So this is another sort of prognostic marker that we get from our exercise stress testing. And this was our impaired heart rate recovery case. Case number 8, a 78-year-old female referred for exercise intolerance and dyspnea on exertion. She undergoes an exercise SPECT MPI. At baseline, she has a heart rate of 82, and after 4 minutes Bruce protocol, she has only increased her peak heart rate to 94, and at that point she had severe fatigue and mild dyspnea. And so this patient was found to have chronotropic incompetence, and a pacemaker was placed with full resolution of her symptoms. And so not only can chronotropic incompetence explain symptoms, but it also, if you look at the graph on the right, you can see that low chronotropic index has prognostic significance for survival, with patients with low chronotropic index having a similar survival to those who had perfusion defects on thallium stress testing in about 3,000 patients. And if you had both defects and chronotropic incompetence, then you did very poorly. Case number 9, a 49-year-old obese male referred for exercise intolerance and dyspnea on exertion. So he underwent an exercise SPECT MPI and went 5 minutes on the Bruce protocol. He had a marked increase in his heart rate, no ECG changes. He stopped for fatigue and dyspnea, and his SPECT was normal. So we thought that this patient was likely to have exercise intolerance. So he underwent VO2 testing, and he was found to have an RER of 0.9, which indicates that he really didn't get to the point where he actually had metabolic anaerobic he never reached the anaerobic threshold, and his VO2 was pretty low. And so these things suggested that he had marked exercise, marked deconditioning. So we referred him for exercise conditioning and weight loss. He was fairly markedly obese, and he had a very good result. So we get information on deconditioning as well from exercise stress. So let's talk a little bit about other potential findings that we could see on exercise. So, and this is a case series. So the first would be a 61-year-old male who had exercise-induced left bundle branch block at 6 minutes of the Bruce protocol. Another patient, a 49-year-old female, had exercise-induced frequent PVCs, and these persisted into recovery. A 72-year-old female, undiagnosed AFib that developed, and a 34-year-old female who developed SVT. So the question is, are these significant? So certainly it's important to identify them. So if you had a patient referred for palpitations and chest heaviness who gets SVT, and the second she does, she gets chest heaviness, you've got your answers to where her symptoms are coming from. Likewise, diagnosing atrial fibrillation is certainly a good thing. But what is the prognostic significance of these things? So if we look at the risk of abnormalities determined on stress testing, we can see that having an exercise-induced left bundle or PVCs both have prognostic significance, whereas SVT, AFib, and PACs do not indicate a higher risk of ischemia or of downstream prognosis from an exercise stress standpoint. So here there are two graphs. You can see the top graph shows ventricular ectopy or PVCs, and you can see that having PVCs during exercise increases your risk of mortality, and during recovery even more so, and during both kind of the most, and likewise a significant decrease in survival in patients who have exercise-induced left bundle branch block. So there's relevance in the precipitation of abnormal rhythms in stress testing during exercise stress. So moving on to another case series. So are there any indications in which one shouldn't have pharmacologic testing? So here we have a 44-year-old female with poorly controlled asthma undergoing evaluation for dyspnea. Then there's someone with a 74-year-old male with longstanding tobacco and COPD on multiple medications, known history of AFib. So the 44-year-old has asthma, and so there's concern about precipitating bronchoconstriction and bronchospasm with RegAdenosine. Likewise, this patient has COPD, which might not necessarily be an issue, but he does have wheezing on auscultation. And because of his known history of AFib, we'd rather not put him through dobutamine. And then an 82-year-old male referred for pharmacologic MPI who had Mobitz 1 second-degree AV block. And that's the reason that we don't want to be using a vasodilator because of the risk of heart block. And this is important. We talked to him about exercise, being willing to try exercise, and he's like, sure. Nobody thought he would be willing to, but he sort of didn't look like somebody who'd be a big exerciser, but he was very willing, and he ended up going 6 minutes, and he had a successful SPECT MPI. So, and then the question is, there are some patients in whom you need to do pharmacologic imaging. So chronic left bundle branch block, pacemaker, patient who have several falls, Parkinson's disease, presented walking slowly with a cane, or you have a positive troponin in the last 48 hours. Those patients need to have pharmacologic stress. So then the question is, so you decide to do exercise testing, and the patient ends up not getting to a diagnostic level. So here we have a 52-year-old male, prior coronary disease. He's on a beta blocker. He took the beta blocker the morning of his test. His cardiologist was called because we said, it may be relevant in somebody with known CAD to keep them on their medicine, but the cardiologist specifically wanted to maximize sensitivity. So we really wanted the beta blocker to be off. So probably the right thing to do at that point would be to actually stop and have the patient come back. But this patient ended up going that day and had a 9-minute Bruce protocol, had only 78% maximum age predicted heart rate achieved. Patient was injected, and the SPECT MPI was negative, and the chest pain continued. So the question is, does this patient actually have obstructive coronary disease? So the first question is that failure to reach target heart rate actually has prognostic significance. You can see there's a higher incidence of coronary heart disease and mortality if you fail to reach your target heart rate. And likewise, the maximum heart rate achieved has a significant impact on accuracy of your test. So in a study by Halatki et al., and this was in the 80s, 1,400 patients with CAD were tested, and they looked at variables that affected the sensitivity or accuracy of their testing. And they found that the max heart rate predicted, that 5 variables affected the sensitivity. And the most prominent of these was the maximal exercise heart rate. If you look at the table on the right, the chi-square, which is sort of the marker for how significant a marker this variable was 10-fold higher for maximum exercise heart rate. So this was a very significant variable. When they looked at specificity, maximum heart rate was the only variable that predicted specificity. And this makes sense. The higher you get your heart rate, the more likely you're going to identify disease that the patient has. And likewise, inability to reach an appropriate age predicted heart rate of 85% of your maximum age predicted can underestimate the extent of disease. So in this study by Amy Iskandrian et al., you can see that patients in blue who had less than 85% of their maximum age predicted heart rate had a lower incidence or sensitivity for one vessel disease, 3 vessel disease, and all vessel disease when compared to those who were able to achieve greater than 85% maximum age predicted heart rate. So this is very important. Not only do you have a decreased sensitivity, but you also underestimate the extent of disease. So if we had taken our last series and revised it and said, okay, same patient, but he achieved 78%. So what if we had him stop right then? We didn't inject for SPECT, and we allowed him to recover for 15 minutes. We could then inject him with RegAdenosine and do a pharmacologic protocol. Likewise, if he had achieved 78%, but said, I can only exercise for another minute, and we knew we weren't going to get there, we could have actually injected him with the vasodilator right then and had him continue to peak exercise over the next minute and then recover. Or we could have immediately slowed him down to a low-level exercise, a slow walk on the treadmill, and we could have injected him. So we have 3 different ways that we could incorporate a vasodilator in, and get a diagnostic test, whereas 78% would not be considered diagnostic. And this is a combined exercise vasodilator protocol. There have been multiple trials that have looked at doing this kind of combined protocol, and they've looked, so for instance, the RegX trial looked at a higher number of patients than this, but there were 39 patients who achieved both exercise RegAdenosine, who had two different protocols. They had an exercise RegAdenosine protocol, and they had a RegAdenosine supine alone protocol. And what you can see, if you look at this bar graph on the left, is that the overall image quality was the same or better. Those are the red striped and red solid bars. Overall, there were no patients who had worse image quality. And the same thing when you look specifically at subdiaphragmatic interference. So this indicates that you get equivalent imaging quality results. And this bar graph on the right, they looked at the adenosine only here. I guess so adenosine only, and then on the which is the vertical axis, and on the horizontal axis you've got the RegAdenosine exercise combined protocol. And so ideally you would see that the numbers would be in these gray boxes, sort of on the 45-degree line, where if you have two defects on the adenosine supine, you have two on the RegX. And you can see that most of them did fall in the same. And if anything, the RegAdenosine exercise group actually identified more defects. So it was even better. And all these findings were similar in a trial called the Burst trial, where you got both exercise RegAdenosine stress first. How about the safety of doing this protocol? Multiple trials have now been completed, and they have shown no major adverse cardiovascular events, and they had similar incidences of both stress-induced arrhythmias as well as hemodynamic changes. So it's very safe to do a combined protocol. Finally, how about side effects? And what you can see here is that if you had, in this study, they looked at, we'll focus on the right, basically that if we looked at chest pain, dyspnea, and ST depression, that there was no higher incidence in the combined protocol of any significance. And actually, it was good to identify chest pain and dyspnea. But what you can see on the right here is the RegAdenosine symptoms were markedly higher in this dark blue. And this doesn't project that well, at least on my screen. But this is the patients who had this supine RegAdenosine is on the far right. So basically, doing RegAdenosine with low-level exercise or right after peak stress was actually associated with a much lower incidence of the RegAdenosine side effects. Whereas the symptoms that you want to identify, chest pain, dyspnea, and ST depression, they had a higher incidence. And I'd already mentioned there are multiple ways to do this protocol. So the end result of this is exercise stress is important. And it turns out that the complication rate overall is very low. The event rate is 1 out of 10,000 for mortality or significant events. You can see here very low rate of deaths and MIs. And in terms of lab preparation, it's just important that you have supervision by someone with experience in cardiovascular emergencies. ACLS certification would be encouraged, and BLS would be absolutely necessary. You're going to want to have emergency equipment on hand, including a defibrillator, oxygen, etc. Most of these things you would need if you were doing vasodilator stress anyway. And there's a variety of drugs that should be nearby if available. So I just threw that in for your sort of perusal. I'm going to not talk about the paradigm for ischemia assessment because the basic gist of this is if they can exercise, do exercise. sometimes you might have a special clinical question where you need advanced imaging, such as their coronary calcium or microvascular function. But that's what that slide shows. So in conclusion, exercise is the preferred stress modality in most situations. It has numerous advantages that we've detailed in 14, 15 cases that improve diagnostic accuracy and really enrich your stress testing sort of findings. An inadequate heart rate response substantially reduces sensitivity and underestimates the extent of disease. And so in these situations, you absolutely should not inject, but do a combined exercise vasodilator protocol unless there's some reason that the patient cannot receive a vasodilator. And exercise vasodilator protocols can be performed safely with reduced side effects and similar sensitivity to vasodilator stress alone. So that was a whirlwind tour of sort of exercise stress and the advantages and some of the data that goes along with some clinical cases. We talked about how to do a combined protocol and why we need combined exercise vasodilator protocols. And so at this point, I'd like to open the floor for questions and try to provide answers best I can, or at least refer you to where you might find the information. And I appreciate you all joining and listening.
Okay, thank you. At this time, we'll begin the Q&A session. From IAC, I'd like to introduce Maria Costello, Director of Accreditation for Nuclear PET, who will be assisting with questions today. Maria, would you like to start us off?
I will. Thank you, Kelly. So the first question, due to the shortage of aminophylline, what are your reversal plans of Lexiscan?
So this is an excellent question and one that we have been working with and struggling with for a while. And what we are doing, we are hoarding our aminophylline as best we can right now and saving the bottles that we have specifically for patients who have a very profound reaction to RegAdenosine. So if, someone who has third-degree heart block, somebody who has profound bronchospasm and we think we're going to have to intubate, somebody who has severe unremitting chest pain, those patients, we're saving the aminophylline best we can. For everybody else, and we were reversing, frankly, more patients than I would have liked, but we were reversing a fair number for things like nausea, diarrhea, a little bit of shortness of breath, a bad headache. For those patients, if they're able to tolerate it, we're giving them a soda, giving them a Coke or a Pepsi. Frankly, the sugar and the caffeine in that does wonders to reverse those symptoms. And so I think in a lot of patients, that or a cup of coffee can kind of fix the problem. Certainly, there's some patients where their issue is nausea, in whom giving them a soda is not a great idea. Or if they're about to go under the camera, that can be an issue. For those patients, we're either giving them the nausea patients, we're actually starting with 4 milligrams of IV Zofran. We've run into a trouble that there's a shortage of that as well, which is just very sad, all of these shortages now, in which case we're giving PO Zofran, but we actually have IV caffeine. And I'm forgetting the dose. I think it's 80 milligrams IV, but there's a paper out recently in the Journal of Nuclear Cardiology within the last couple of years that specifically talks about IV caffeine. So that's what we're using.
Okay, the next question. If a patient is scheduled for an exercise stress test and they exercise for about 10 minutes using the Bruce protocol, but they don't meet 85% of the target heart rate, what is the best practice? Especially if the patient gets to 81 to 83%.
So this wasn't planted from my lab, was it, Maria?
Not that I know of.
This was a long battle on this, and I will tell you that from an ideal standpoint, you would still stop and do a RegAdenosine stress on those patients because anything below 85% is not as sensitive. That having been said, there is the reality of it. And so actually in our lab, if a patient can go 10 mets or more, 9 minutes on the treadmill, we use a cutoff of 80%. I have no data to back that up, so please do not quote that as data. That is just, there was all-out revolt in our stress lab if we were going to do anything different, and so we compromised and did that. But if I had my full druthers, we probably would do RegAdenosine. Now, you can take that to a ridiculous level. If they reach 84%, I'd probably accept that, 83%. Down towards 80%, I start getting a little more nervous.
Okay. The next question, what about combined exercise with persantine? Is that, I'm assuming this means, is that an okay protocol?
Right. So I would think that any of the vasodilators would theoretically be okay. I don't know of any studies that have, I think one of the studies actually did look, there was a diprodamol arm. So I think it probably would be fine. There's more data with RegAdenosine. I do think you have to be, obviously prepared for reversal. But otherwise, I think that would probably be fine.
Okay. Next question. I noticed that it was noted that there was a 15-minute waiting period when switching from an exercise to a pharmacologic test. Is it important to wait a full 15 minutes before starting the pharmacologic test?
Thank you for that clarification. And I tried to clarify a little bit on my slides, or while I was giving the slide. So in that particular case, so the way I think of it is there's sort of three different ways to do this. One is that if you think you've got a little bit more time at peak stress, but that they're not going to get there, let's say they're at 75%, or they've been rock solid at 78% and they're not going to get there, then go ahead and inject at peak stress right then. Let them exercise for a minute, and then you recover them as normal. And it's almost like they never got it, but yet it gives you the sort of full sensitivity. So that's one way to do it. Another is for somebody where they're done and they're not going to exercise any longer, but they think that they can still walk on the treadmill a little bit. I think that that's kind of the best second alternative, because you can give them the RegAdenosine and or the vasodilator and have them exercise at a low, at a low exercise rate right then, and then recover them afterwards. But there are some patients who need to stop the treadmill right now. And for those patients, it is fine to stop and recover them, and you can recover them for as long as you want. If they're good to go in 3 minutes, do it at 3 minutes. If they're, good to go at 15, fine. Some patients might want to wait a half an hour before they do it, or logistically, you may need to wait a half an hour before you do it. That's all fine. So really, it becomes a totally separate test once you've waited more than a couple of minutes. And at that point, it really doesn't matter how long you wait.
Okay. Do you typically use a modified Bruce protocol for a combined study?
For a combined study, like
meaning,
exercise spec?
I think it means when you're doing RegAdenosine, if you know that they can't walk that far, would you still use a modified Bruce protocol, or would you just keep them at a low level?
So I think that my thought on that would be, if you're just using the exercise to ameliorate the side effects, then I would just do low-level walking. I don't think throwing them into a Bruce protocol or modified Bruce is going to do a whole lot. If you're actually going to run it as an exercise stress, then I think you want to run the exercise stress through, and then you do the RegAdenosine or the vasodilator if you have to. So it's really important that if you're going to do an exercise stress, that you do it in a symptom-limited fashion, because what you don't want to do is give your referring inaccurate. You don't want to give them misleading information. So, for instance, if you're not really intending to exercise them to their peak, And so you sort of stop them after 4 minutes and you document 4 minutes on a modified or a Bruce protocol. Everybody's going to think that patient has a really poor exercise capacity. And maybe it's just that, you just didn't take them that far. So I'd be very careful about that. So I would say probably either start with exercise, which would be my preference, or if you know that they can't, and importantly, let them fail. It is okay if you think a patient is safe, but can only go 3 minutes. That's really valuable information. And sometimes you get ST changes and angina within those 3 minutes and you've got a diagnostic test and you're done. But it's important not to go, oh, I don't think they're going to get there. I don't think they're going to make it. So don't switch those patients to vasodilator. Now, on the other hand, if it's a patient who comes in with a cane and they're walking real slow, or, that they're not going to be able to be safe on the treadmill, that's a totally different story. Those patients should get vasodilator straight out. But the whole, 50 to 60% of studies being vasodilator is really not necessary.
Okay. Next question. What are your thoughts for injecting a patient who does not achieve heart rate but has 7 out of 10 for chest pain and 2 to 3 millimeter ECG changes? Should we inject them with the radioisotope or switch to RegAdenosine?
So for those patients, I would go. So if you have clear evidence of ischemia, and I would say that if you've got ST changes, especially multimillimeter, and you've got recreation of their symptoms or something that looks like angina, I would go ahead and inject. I think you've got a diagnostic study at that point. You don't have to do a vasodilator. If there's any question, you can stop and then do the vasodilator, and you will still get diagnostic images, and you haven't lost the ability to document that you had, some kind of symptoms and ECG changes during exercise. So you win both ways. But I would say in that case, you probably could have injected without doing a vasodilator. But I would err on the side of caution in doing a vasodilator if you're not sure, because there's nothing worse than making that decision. And it all depends on your lab. But at UVA, we have the reader is not the one doing the stress test. And so you don't want the reader to come back and say, why did you inject this patient? So I'd err on the side of caution.
Okay. Do you consider an exercise stress test as adequate or diagnostic if the patient achieves less than 7 METs, but is at least 85% of the maximum heart rate?
So in our lab, we require that they go at least 6 minutes on the Bruce protocol and that they've reached 85%. So I don't count it as less than 6 minutes unless there's some other clear sign of ischemia. So in those patients, we'll switch to a vasodilator. It's a good question. I know that some labs do that. Our philosophy is that it's you're not so just because you have an exaggerated heart rate response and deconditioning doesn't mean that you've necessarily put your heart through the amount of work necessary to maximize the sensitivity of the test.
Okay. We probably have time for 1 or 2 more questions. Caffeine affects LexaScan. Would it still impact a combined exercise LexaScan study?
It would. So I think if you know that, if you think there's any chance that you're going to have to do a LexaScan combined protocol, then you need to recognize that the LexaScan. So if RegAdenosine is not accurate by itself because of caffeine, it's going to be the same thing in a combined protocol. Now, what you could do is exercise the patient, and if they reach it and have a diagnostic study, then you're done. They don't have to come back. But if they don't reach diagnostic heart rate and workload, then I would stop the test, recover them, and have them come back on a separate day for their vasodilator.
Okay. And I think we have time for one more question. If a pharmacologic stress cannot walk on the treadmill, do you see value in having the patient do leg lifts or upper extremity exercises of some kind?
Yes, I do see potential value in it. Practically speaking, we have not done much of that in our lab, only because often the patients who are vasodilator and unable to walk on the treadmill are generally the same ones that are not super excited about doing any kind of leg lifts or upper extremity exercise. And so practically it just hasn't worked out that way. But I think anything you can do, frankly, I think if anything, it's a distraction to the patient and it gets them off of the fact that they've got a twinge of abdominal discomfort or a little headache because they're focused on doing whatever task you've given them. So I think it's probably worthwhile.
Okay. All right, we'll do one more and then that's it. For clarification, if a patient is unable to meet peak exercise but can continue to walk slowly on the treadmill, is it okay to inject the RegAdenosine immediately, followed by the tracer, and then recover? So, yes. Okay. Wasn't sure if that needed clarification.
So you absolutely can use the RegAdenosine at any point in the study. You don't want to use it before peak stress or a minute before peak stress because they might reach heart rate and workload. So you don't want to give it early, but you can give it at peak stress. You can give it at peak stress and immediately drop them down to low exercise workload. Ideally, you exercise them for an additional minute at peak, but you don't have to. They can drop down to a low workload, or you can drop them to a low workload, give them 2 minutes to recover, and then inject it and have them continue walking. Or you can stop the treadmill and inject it with them lying on the gurney. There really there are multiple ways to skin the cat.
Okay, and that's all we have time for. So I will turn it back over to Kelly.
Okay, thank you, Maria, and thanks again, everyone. And a very special thank you to Dr. Bourque for his presentation today. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session and also be available from the IAC webinars portal for 3 business days. On the left side of the My Account page, you'll click on Webinars. Look for the title of this session, Stress Selection, Exercise is Key, but Sometimes You Need a Pharmacologic Boost. Beneath this title, you will see the button Attend Event. Click this button, then the Evaluation tab, then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen and anytime thereafter through the CE transcript section on the My Account page. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.